Smoking doesn't just harm the smoker, it reaches across the placenta and harms baby. From infertility to low birth weight, tobacco smoke interferes with reproductive health and fetal development. When we talk about smoking-related disease, we often focus on cancer, heart disease, and lung damage. But one of the most disturbing aspects of tobacco smoking is its impact on reproduction and early life development. The damage begins well before a cigarette is lit during pregnancy. Smoking affects fertility, conception, fetal development, and long-term child health. So let's start with female fertility. Women who smoke take longer to conceive. They're more likely to experience infertility, and when they do conceive, they are at increased risk of ectopic pregnancy and miscarriage. Why? Well, tobacco smoking interferes with hormone production, reduces oocyte quality, and damages the fallopian tubes. Studies show a dose-dependent reduction in fertility with cigarette exposure, even in women undergoing assisted reproductive technologies like IVF. Smoking also accelerates ovarian aging. It reduces the ovarian reserve and brings on menopause earlier by 1 to 4 years. In men, smoking affects sperm quality, lower counts, reduced motility, abnormal morphology, and increased DNA fragmentation. It also lowers testosterone levels and may contribute to erectile dysfunction through vascular injury. Now let's move to pregnancy. When a pregnant woman smokes, she exposes her fetus to thousands of harmful chemicals. Nicotine, carbon monoxide, heavy metals, and carcinogens all cross the placenta. Nicotine restricts uterine blood flow, which limits the delivery of oxygen and nutrients. Carbon monoxide further reduces oxygen availability by binding to fetal hemoglobin. The result is fetal hypoxia, a major contributor to developmental problems. Smoking during pregnancy increases the risk of placental abruption, placenta previa, premature rupture of membranes, preterm birth, intrauterine growth restriction, and stillbirth. One of the most consistent findings across decades of research is low birth weight. On average, babies born to smokers weigh 200 to 300 grams less than those born to non-smokers, and the more cigarettes smoked per day, the greater the weight reduction. Importantly, smoking also alters placental structure, thickened membranes, calcifications, reduced surface area, and impairs nutrient transport. There's also strong evidence that smoking increases the risk of congenital abnormalities. These include orofacial clefts like cleft lip and cleft palate, limb defects, gastroschisis, neural tube defects. Although the absolute risk is small, the association is consistent and biologically plausible. Let's talk about neurodevelopment. Prenatal nicotine exposure affects brain development. It alters the formation of neural pathways involved in learning, memory, attention, and behavioral regulation. As a result, children of smokers have higher rates of ADHD, learning difficulties, behavioral disorders, and lower academic achievement. Some of these effects are seen even when the mother quits in the second trimester, highlighting the sensitivity of fetal brain development early in pregnancy. And then there's the increased risk of sudden infant death syndrome, SIDS. Smoking during and after pregnancy significantly increases the risk of SIDS. The mechanism likely involves impaired arousal responses, reduced autonomic stability, and altered brainstem development. This is why smoking cessation is a key part of antenatal and postnatal care. And what about secondhand smoke? Even women who don't smoke but are exposed to others' smoke during pregnancy face increased risks of low birth weight and stillbirth. After birth, infants exposed to secondhand smoke are more likely to develop asthma, wheezing, respiratory infections, otitis media. This exposure often continues in the home, with effects accumulating over time. There's also growing concern about epigenetic effects. Tobacco smoke can alter gene expression in the fetus without changing the DNA sequence. These changes may persist into adulthood, increasing the risk of metabolic syndrome, obesity, hypertension, and type 2 diabetes later on in life. In other words, smoking during pregnancy doesn't just affect birth outcomes, it may program disease risk across the child's entire lifespan. Now let's talk about smoking cessation in pregnancy. It works. Quitting early in pregnancy, especially in the first trimester, greatly reduces the risks, but even quitting later provides benefits: improved birth weight, reduced risk of preterm labor, and better neonatal outcomes. Nicotine replacement therapy is sometimes considered, but always requires careful weighing up of risks and benefits. Behavioral support and counseling remain first line. From a clinical perspective, here's what matters. Ask about smoking at every visit. Many pregnant people underreport report tobacco use, so ask early, ask often, and ask clearly. Discuss secondhand smoke. Ask who smokes at home. Encourage household changes such as designated outdoor areas or full smoking bans indoors. Reinforce the benefits. Many people don't realize how quickly risk drops after quitting, even mid-pregnancy. Include partners. Encouraging both parents to quit creates a healthier home environment and improves long-term outcomes for baby. Continue support postpartum. Many people relapse after delivery. Make smoking cessation part of newborn care at follow-up. Also, don't overlook reproductive age patients who aren't yet pregnant. Smoking cessation counselling should be part of routine contraceptive and fertility care. When patients understand that smoking can impair fertility and harm future children, their motivation to quit often increases. And here's a practical tip. Shift the frame from blame to protection. Focus on what people can do now to support a healthier pregnancy or future family, not what they've done wrong in the past. Let's finish with this. Smoking is not just a personal risk, it's a transgenerational exposure risk. When someone smokes during pregnancy, they're not just affecting their own body, they're changing the trajectory of their child's health and potentially their grandchild's. The sooner we act, the more damage we can prevent before it ever begins. That's all for today, folks. My name is Dr. Ferghal Armstrong, and this has been Cracking Addiction.